Hello, my name is Charlie Till and I'm one of the education team with the Scottish Ambulance Service. Today we're going to look at the cardiorespiratory examination, where we're looking at the cardiovascular system, the heart and the respiratory system, mainly the lungs. We're going to run through this, and before it we'll always have completed a preliminary examination which you'll have just seen on the previous video. I'm going to start by assessing for any jugular venous distension, where I'm going to look for the jugular venous pulse. So I'm just going to get you to rest your head back slightly for me and just turn it so it's about a 45-degree angle. That's perfect. I'm looking at where I know the external jugular vein would sit on the neck, and I'm looking to see if there's any obvious distension of that vein. If there is, I'm going to take note of how far up the neck it is distended. We know jugular venous distension can be a sign of right heart failure, congestive heart failure, or any other obstructive problem preventing flow back into the thoracic cavity and the heart. Next, I'm going to palpate for a carotid pulse. And once I've located it, I'm going to auscultate over the carotid pulse with the diaphragm of my stethoscope. I'm listening for any bruits or hums. Bruits are the sound of turbulent flow within the carotid artery, which is a sign of a build-up of plaque within that artery. And hums are transferred sounds of potentially a compromised heart valve and the sounds travelling up, and you're hearing it through the carotid artery. So I'm just going to have a listen there. I'm now going to inspect the patient's chest. I'm looking in general for any scars suggestive of old surgeries. I'm looking for any potentially implanted cardiac devices such as pacemakers or defibrillators. I'm looking for any other wounds that could suggest previous injury. I'm looking at the shape of the chest. I'm looking for any rashes, any bruising, and I'm also assessing their work of breathing and making sure that there's no accessory muscle use through intercostal recession, tracheal tug, sternal recession. I'm now going to palpate the chest. First of all, I'm going to check for equal expansion and excursion. So I'm going to place the flats of my hand on either side of the sternum and just ask to take a deep breath in for me and out again. That's fantastic. So I'm looking for that classic lung bucket handle movement, and I'm expecting my hands to lift up off of the chest equally. I'm going to do the same again by placing my thumbs on either side of the patient's zippy sternum and my hands around the lower ribs. And I'm going to get you to take another deep breath in and out again. And here I'm using my thumbs to assess for equality on both sides, and I'm expecting them to move slightly but the same. What may happen is one may move more than the other, and that's a good way of picking up any subtle differences from left to right. After this, I'm going to check for tactile fremitus, which is also part of my palpation of the chest. I'm going to use the ulnar aspect of both of my hands to feel for vibrations. For when the patient is speaking, the vibration will come through the chest and onto my hand. So I'm going to place them again on either side of the sternum and just ask the patient to say 99 for me.
99.
Fantastic. And I'm going to place them again in the fifth intercostal space. Just say 99 for me.
99.
Fantastic. If I feel reduced vibration in an area, that's a sign of consolidation, and I can then hone in on that area by placing my hands and getting the patient to say 99 repeatedly to map out the area of consolidation which I've identified. Cardiac palpation is where we're feeling for the apical beat, which is the strongest point of the heartbeat being felt through the chest. That's usually around the fifth intercostal space, mid-clavicular line, though it varies depending on the patient. If they suffer from hypertrophy, then it can be more lateral due to the rotation of the heart. To do this, I'm going to start with the palm of my hand, and I'm putting it in the rough area of the fifth intercostal space, mid-clavicular line, and I'm feeling to see if I can feel any heartbeat against the palm of my hand. If I can, I'm then going to focus in on that area, again with the ulnar aspect, placing it where I felt the beat, and compare that to the patient's radial pulse to check for any delay. If I'm struggling to feel the patient's apical beat, which can happen and is normal in some patients, I'm going to keep my hand in that position and just get them to sit slightly forward for me, and also just lean slightly over onto your left side. And that helps bring the heart closer to the front of the chest and may make it easier for you to find that point. Okay, you can relax back now. Thank you. Once I've palpated the chest, I'm then going to percuss the lung fields. I'm going to start at the top and move down in a J shape, coming round until I meet the mid-axillary line, going right round to the side, remembering that the chest is a 3D structure and I'm not just checking the front. I'm also making sure that when I percuss, I don't come too low, because I will actually then percuss over the patient's liver, which will give me a false reading because I'll be picking up dullness, which is meant to be there. Remember that the diphisternum around here is actually the point where the diaphragm sits, and so we've got a lot of ribs here that are all covering the abdomen, where we wouldn't be percussing lung if we were to percuss over them. As I percuss, I'm going to percuss on both sides of the chest, back and forward, so I'm comparing each side as I go, and I'm making sure that I'm percussing properly to create good sound. So I'm placing my middle finger with the middle segment of that finger in the intercostal space. I'm taking my dominant hand and I'm taking 2 fingers so that they are hook-like, and I'm treating them like a drum, and I'm tapping on the chest and creating a good percussion sound there. I'm going to compare it on both sides and move down in at least 7 points on each side, comparing the chest. If I need to, I can turn my hand to get good contact with the skin as I come round the chest. And that's percussion complete. I'm now going to auscultate the chest. We're going to divide auscultation, starting with respiratory auscultation, where we listen to the lung fields, and then we're going to do cardiac auscultation, where we listen to the heart sounds. For lung auscultation, we're using the diaphragm of our stethoscope, so we need to make sure that's engaged. And I'm going to listen in the same points that I just percussed on both sides of the chest, moving back and forward to compare sides. And also I need to take my time, because we want to listen to a full lung cycle of a breathing in and a breathing out. And what we can't do is immediately move our stethoscope on, because we'll get to the next breath sound halfway through in the time it takes to move the stethoscope. So we're going to relax and listen to a good breath and a half at least in each position. If we hear any crepitations, we'll ask the patient to do a small cough, and if that clears, we'll just believe that that is normal lung secretion and not any pathological cause. So just turn your head slightly that way for me, and just take a nice normal breath in and out for me. Fantastic. And again. And I'll fast forward. Again, making sure that my final points of auscultation on both sides were right round under the arm, so I'm assessing all the lung fields. I'm now going to go on to cardiac auscultation. For that, I need to make sure that the bell of my stethoscope is engaged, and I'm rotating that round. And I'm going to listen to the 4 different heart valves. So I'm listening in 4 locations, and I'm looking for the 2 heart sounds, which are termed S1 and S2. Anything abnormal could either present as an extra heart sound. So instead of lub dub, we may hear lub dub dub or lub dub, or an additional sound. Or we may just hear some poorer quality of one of the heart sounds, so lub dub or lub dub, something like that. We're not trying to identify a specific problem if there is an abnormality in the heart sounds. We're simply identifying that it is not normal, and then signposting the patient to the right place where they can be further assessed. Usually that would be at the hospital. My first point of auscultation will be in the 4th intercostal space on the patient's right-hand side, roughly where we would put lead V1 in a 12-lead ECG, and that's listening to the aortic valve. I'm going to check the patient's radial pulse at the same time, making sure that they beat at the same time and that there's no delay. Initially, you will hear breath sounds, and it takes a few moments for your brain to tune out those breath sounds so you can start to focus in on the heart sounds, and you'll often find it feels like the heart sounds get louder the longer you're listening as your ear picks them up better. So feel free to listen for a good few seconds and make sure you listen clearly. I'm then going to listen in the mirror position, which is the fourth intercostal space on the left-hand side. I'm then going to listen at the second site, which is in the opposite side of the chest. So that's the fourth intercostal space on the left-hand side, where we'd put lead V2 of a 12-lead ECG, and that is listening to the pulmonary valve. And I'm going to listen there again. After that, I'm going to come down and listen to the tricuspid valve, which is roughly located in the midclavicular line, fifth intercostal space. So again, we're palpating and finding that intercostal space and making sure we're placing the stethoscope between the ribs and not listening to a rib. And this is roughly where you'd put lead V4 of a 12-lead. And the final point of auscultation is, again, roughly in the anterior axillary line around V5 and V6, fifth intercostal space, and that is the mitral valve. And I'm going to listen there as well. So I'm listening to all four locations and palpating the radial pulse with each location. Now I'm going to need to assess the patient's back. What I'm not doing is assessing the front and then the back, the front and then the back with each percussion, palpation, auscultation, because that's too much movement for the patient. Instead, I'm going to complete the assessment of the front of the chest and then ask my patient to move so I can assess the back of the chest. Would you be able to sit up and just rotate your legs away from me? And we'll just turn right round here. Fantastic. Just a little bit more. There we go, perfect. I'm carrying out the same set of inspection, palpation, percussion and auscultation on the patient's back. I'm starting by inspecting for the same things as I was looking for on the front, with the addition of checking for any signs of sacral edema on the lower back, particularly in bed-bound patients. After that, I'm going to check for palpation. I'm not looking for expansion as much because the posterior ribs don't move normally as part of breathing. That's the front of the chest. But what I am doing is assessing for tactile fremitus. So again, the ulnar aspects of my hand on either side of the spine, making sure they're not over the shoulder blades. Just say 99 for me.
99.
Fantastic. And then I'm moving them more laterally underneath the shoulder blades. Just say 99.
99.
Again, remembering that I don't want to go too low and palpate below the level of the lungs. Once I've done that, I'm going to percuss, and for this I'm going to get the patient to cross their arms in front of their chest, and what that does is it sort of wings the shoulder blades slightly out of the way, giving us better access to the underlying posterior ribs. I'm going to percuss down, again in a J shape, comparing both sides. And I'm making sure that my final point of percussion is next to where my final point of percussion was on the front of the chest. So overall, I've assessed down, around, under, and then coming back round on the front. So I've assessed the full 3D aspect of the lung fields. I'm then going to auscultate the patient's lungs, making sure I've changed back to the diaphragm of my stethoscope. And I'm going to listen in the same place as I've percussed. Just take a normal breath in and out for me. And again. And again. And I'm fast forwarding. Once I've finished auscultating the chest, I can get the patient to move back so that they are on the bed again. So if you just want to swing back round, if that's all right, fantastic. I'm now going to do a quick assessment of the patient's abdomen to make sure there's no cardiovascular signs there. What I may need to do is get them to lie slightly flatter. So I'm just going to make the bed slightly flatter for you. There we go, just relax back. Once I've assessed the patient's back and they're now lying in a normal position again, I'm going to lie them slightly flatter and do a quick assessment of the abdomen for any cardiovascular signs. I'm going to start by dropping down to their level and looking across the abdomen for any pulsating masses, which could be a sign of abdominal aortic aneurysm. And I'm also going to look to see if there's any obvious distension and swelling, which could be a sign of ascites. I'm going to listen to the left of the umbilicus, so that's the left of the patient's belly button, and that's where the descending aorta will lie. And I'm listening again for any bruise, so any sign of turbulent flow within the aorta. If you feel the need to, based on your findings, you may carry out more of an abdominal assessment, which we'll cover in another video. Finally, I'm going to assess the patient's lower limbs from a cardiac point of view. Is it okay if I just pull your trousers up slightly? So I'm going to pull up, making sure I'm exposing the calf muscle on both legs. And I'm looking for any general signs of ischemia, any areas where the leg hair looks like it's growing less and there's any open patches. That could suggest that there's been ongoing ischemia in the lower limbs. I'm going to check for my pedal pulses on both sides, make sure that they're present. And I'm also going to feel both legs to make sure they're of equal temperature. If one was warmer than the other, that gives me an increased concern that there's potential for some form of DVT. I'm also going to palpate both of the calf muscles. Is that uncomfortable? Fantastic. Is this uncomfortable? Fantastic. And I'm also looking to make sure neither of them is swollen on one side and checking for any peripheral edema or ankle edema on both legs. Once I've completed my cardiorespiratory assessment, I'm then going to consider the likely need to carry out a 12-lead ECG if I've not done so already. If it's respiratory, I may carry out a peak expiratory flow rate, which is very important in respiratory patients. I've also got the ability to carry out standing blood pressures, and I could also consider the Wells scores for risk of DVT and PE, depending on the presentation of the patient.